Good evening, everyone, and welcome. Thank you very much for registering for our webinar, Understanding Type 1 Diabetes, Risk Detection, and the Emotional Impact. And this series has been made possible by an unrestricted educational grant from Sanofi Canada. So for that, we're very grateful. My name is Lori Berard. I work as a consultant in diabetes management and clinical trials, and I'll be your host and facilitator for the discussion today. Now, this evening's presentation is the third and final of a three-part webinar series featuring healthcare professionals discussing, initially we talked about risk, and then about the emotional impact of type 1 diabetes. So a couple of housekeeping details. First of all, we will welcome your questions. So you can either submit them in the chat box or the Q&A, and we'll answer as many as possible in the final 10 minutes of our session together. Just remember, we cannot give any personal individualized advice, so we will be answering things in the broader sense. Our session today will be about 20 minutes, and then we'll do Q&A. If you're, have other questions, all of the webinars have been recorded and are available on Diabetes Care Community for future viewing. And there's an amazing written series around this topic that's also available on the website that you can certainly access. And last but not least, we will be sending you a short evaluation at the end to see how you felt about today. And that's what really gives us guidance on what we need to do next for you. So let's get started. If I could move on to the next slide. I've given you a tiny little bit of history for myself. My name's Lori. I work in Winnipeg. I'm a nurse by training. I've worked almost 4 decades in diabetes, and I have a special interest, of course, in research, and I spent many years working in the area of screening for individuals at risk for type 1 diabetes. So I have a bit of a background here. But I'm most delighted tonight to be joined by my friend and colleague, Dr. Michael Vallis. And Michael has an extensive CV and an extensive bio, but what you really need to know about Michael is he's based in Halifax. He's a health psychologist that's internationally known. He has worked all of his career with people with chronic diseases, specifically diabetes, more recently obesity. And I think for many of us that work with individuals living with diabetes, that Michael has been our guiding light to make sure that we have the tough conversations that we're helping people with their emotional needs living with diabetes. So I'm really excited for Michael to take us through this session. If we can move to the next slide, please. Michael, why don't you tell us what we're going to do tonight?
Thank you. Yeah, so thanks, Larry. It's great for the opportunity to have a conversation. Actually, maybe I'll share with you just one of the reasons why I'm so excited about to have this conversation. As a psychologist in diabetes, it's always often been when the medical discoveries happen and the medical interventions happen, they just get implemented. And then the psychological components are kind of left to the end. And so this has been sort of a bit of a pattern. When it comes to this issue of screening for type 1 diabetes, we actually have the opportunity that we haven't had before in diabetes management, which is to bring in the psychological and emotional aspects right at the very, very beginning. So I'm super excited to talk to you about the issue of screening for type 1 diabetes. And I'd love to really normalize that one size does not fit all when it comes to this particular issue. There are very common emotional reactions that people have and a range of emotional experiences, and they are experienced differently by parents, by siblings, by individuals. And so it's really important for us to recognize that when you think about one size does not fit all, then we're not here to judge a person's reaction. I think this is one of the things I really want to come away with. Can we understand people's attitudes, understand people's emotions, and then engage in what we clinicians call shared decision making? We're not here to tell anyone what to do. What we are here to do is to guide people by providing them sufficient information and support so that they can make the decisions that are best for themselves. But I think it's actually important because the nature of this task, that is trying to jump onto a problem before it even happens, is not easy for people to do. And so we want to also be mindful of if something is stressful, that doesn't mean it's bad, but it does mean that you have to cope with it. So coping and resilience and how to access supports can be extremely beneficial. And I think we're going to chat about that tonight.
Excellent. So let's get started, Michael. Like you said, this is really going to be a conversation. So I have a few sort of leading questions for you. Now, this is all new. Most people that were doing this type of screening have been doing it previously in established research protocols. But now there's a bit more of an opportunity and desire. So when families receive a positive type 1 screening or early risk result, like we've talked about in the previous two webinars, what emotional reactions do you think are most common for both the parents, the child themselves, and of course their siblings, because it's a familial thing?
So the first thing to think about is the fact that one of the most difficult things for people to do, for humans really to do, is solve problems before they happen. Commonly known as, if it's not broken, why should I fix it? So what that means then is that if you're going along in life and you haven't had a problem yet, it's actually not easy for people to rush into that area. As a matter of fact, this is where when new information comes in, it's primarily processed emotionally before it's processed logically. And so what we know then is the following. The experience of threat produces the emotion of anxiety. The experience of loss produces the emotion of sadness. And the experience of unfairness or injustice produces the feeling of anger. So you can look at these emotional reactions by thinking, okay, is there any perception of threat? Is there any perception of loss? Is there any perception of unfairness when it comes to the screening for type 1 diabetes? And what's really nice about that is that we're just trying to understand it, to describe it. And because it is the sort of the natural history of how do people make decisions, and they make the decisions emotionally first. And so it's important for us to recognize this, because that is just one side of the coin. That is, what is the perception? And then the second is, what is the response to that? And so we start to take this apart, and then we can understand that, some families, some individuals, even within families, you'll see different reactions, and one isn't right, one isn't wrong. It's really around how do we use the understanding of a person's experience to guide them so that they can fully consider the options, and importantly, go into active coping strategies. What can you do now that you have the perception of this potential for the development of type 1 diabetes? And that's, again, from a medical point of view, as you would have heard in the previous sessions, this is super, super exciting for people.
So I think, Michael, we talked a little bit about this before we even started tonight. So, we've sort of jumped into sort of talking about the receiving the positive result. Do you have any sort of brief comments on even making the decision as a family to do the screening? Like we've talked in the previous webinars about who should be screened and why. But, like I said, we kind of jumped ahead today. I'm just wondering if you think about, is there a right or wrong answer to choosing to screen, and what kind of hesitancy? And this is a bit off the topic for you, but I think it might be, especially if anybody online is thinking about, shouldn't I don't really want to know, but I really want to know. What kind of emotions maybe I answered the question right there.
It's awesome, right? Because that's exactly right. You could imagine that a person would be pulled in two different directions. Right? We know, for instance, that there is a fairly high risk of having diabetes ketoacidosis at diagnosis when type 1 diagnosis is diagnosed suddenly. It can be psychologically traumatic. And so this concept of a soft landing where you have time to prepare before it happens, the idea of lowering the risk of diabetes ketoacidosis depending on the age of a child, perhaps even delaying the diagnosis, all of these makes perfect sense. But then on the other hand, there could be this perception of threat, perception of loss, or perception of unfairness. So I said there was two sides to that coin. One was the emotional reaction, the other is the coping response. So when it comes to considering, are you considering it? What we would ask is for you to reflect on your coping strategies, because we divide coping strategies into three types. And again, there are situations where each of these types of coping strategies is the right thing to do. And those coping strategies are action focused coping. And that tends to be what we kind of talk a lot about in the health system. You have a problem, you immediately want to solve it. Well, that's not how everybody reacts. Some people, when they experience a stress, will go right into active coping. But other people will kind of bury their head in the sand. They'll want to pull away from it, avoidant coping. Just maybe pretend it doesn't happen. And by the way, that's actually pretty normal. And most of us will experience that kind of, oh, I wish this didn't even happen to me. I just want to pretend it didn't happen. That's avoidant coping. And then there's emotion focused coping, where the emotional signal becomes really, really strong. And so I would ask people to reflect on their coping styles so that they can sort of match this. And I would invite clinicians to reflect on the person's coping style so that we can match it to the right circumstance. So if you were a clinician working with someone who has an avoidant tendency, then maybe we would introduce things in a slow way. Importantly, if you're more of an emotion-focused person, then, and you've heard this message from me quite a bit before, we need to really give people the opportunity to experience and express their emotions so that they can go from emotion to logic and get into active coping. So I think it's really important for us to be thinking about this like almost like putting a quilt together when you've got each of the individual sections that you're putting together. And as people reflect on this, then they can think about what is the best decision for them. And importantly, how they can move forward with the decision. Some people, I would imagine, could spend a long time thinking about whether they're going to screen or not. For other people, it may not be a decision that takes them more than a few seconds. They might think, okay, this is it. So I think looking at both emotional response and coping resource, and this is where I think it can be really important. There's no one pathway. What we want to do, I think, is to support people in finding what's right for them by matching their reactions and their coping strategy to the opportunities that screening presents.
And I think this also just sort of lends into the conversation we had a little bit, and we'll move on after this. But I mentioned earlier that, it's been around for a long time. But I think in the year 2026, it's better. Screening is better. Prediction is more precise. Tools are more available. And, we know that there is some promise of intervention. So I think that everybody might feel a little bit differently than they did even, and I said this with Anna the other day, 5 years ago, we wouldn't even be having this conversation because it was all research-based, but now we're moving into something that's more clinical. So let's switch now, Michael, and let's sort of talk a little bit about, okay, so now we've done the screening and all of a sudden you have a positive result and child's perfectly fine or the individual's perfectly fine. So how do the emotions and concerns differ between kids and their parents when they feel well, but now they've been identified as risks? What do you think is going to happen here?
Yeah, I think that's a really important question to think about. And what I would ask families or parents to do is address this issue around what would be called watchful waiting, which is not an uncommon occurrence in chronic diseases where you've got a signal and you're now just in this waiting perspective. Try to make sure that how you address this issue between parent and child would be how a family would handle any other conflict. So you would really use your own sort of knowledge of your family, importantly, the knowledge of your children. So for instance, how much do you tell your child? Well, think about this following question. When do you tell your and I hope there's no children on the call that are young enough, but when do we tell our kids that Santa Claus isn't real? Every family makes that decision, right? Every family goes through that you have to decide how mature is my child. And there are lots of signals out there. And so what I really like to do here, because there is no one pathway, is really help us to set this up. So, and I couldn't agree with you more. 2026 is a really interesting year. I think this is fascinating how the basic science research has accumulated to now the point where we can predict and we can prepare and we are getting towards where we can treat. And so this is huge in terms of its benefits. But I think what it would do is give people the opportunity to figure out what works within their family and at what level and who needs to solve what problem. because, if let's say the child is at risk, then does the child take on any of the preparatory tasks? Perhaps, depending on the child's age, or the parents will take it on. As long as someone takes it on, then it doesn't really matter. So you don't have to, feel like the child has to be getting ready for what it's like to live with type 1 diabetes before it actually happens, when the family can set it up. And one of the things that I think I'm really looking forward to is the opportunity for people to practice how to manage, how to cope before the problem happens. And I think that gives us a very different perspective, because typically with chronic diseases like diabetes, there's no practice runs. There's no, kind of, like the Olympics, right? Take the top two of your three scores, you can throw one away, right? You don't usually get that when, you've got a disease diagnosis. But when you're looking at this risk of developing, then it's great opportunity. And again, what do we know about type 1 diabetes? Oh, what a wonderful opportunity to present. And you know as well as I do that people living with type 1 diabetes are amazing at coping. They juggle so many tasks that are diabetes specific in addition to everything else. So I think that preparation time will be a really interesting thing when we put this together with, as you described, the current landscape in this field.
And it sort of ties really nicely into what Dr. Wiseman talked about on webinar number 2 about what's really important when you go through this is education. And you've really touched on that about the preparedness and the understanding and who needs to own that at whatever time. But what's really important is that when people are well educated, then they know they have some idea of the what next step, or, in the case of, if you're already on monitoring, for example, that you've been educated to what the numbers mean and when to call. So I think that's a really nice tie-in. Let's talk a little bit about, sort of the process though, because now, even if you're educated and you're somewhat prepared and you're monitoring and you're waiting, like, what do you think some of the best coping strategies are for people in this time period where they're constantly thinking about they have to have repeat screening down the road. They have to be doing some monitoring. They're never quite sure about what progression looks like. So what would you sort of advise there?
I think that's a great question. And I think a really useful way to think about it would be to think about the experience of stress. And what I mean by that is, what are you thinking? What are you feeling? What are you doing? And if we think about those three aspects of the experience of stressful events, then we can start to think about what do we do in terms of managing our thoughts, right? And that's where we can sort of like, how are we experiencing this? And I'd like to suggest that given the nature of this particular task, we as health professionals need to recognize that decisions won't be made quickly, and they don't need to be made quickly. I think this is a great opportunity for us to really understand that. I sometimes say that people don't make the right decisions. When you make a decision that's correct for you, it's usually the decision makes you. That is, you sit with it long enough that you kind of think, you know what, I got this gut feeling this is right for me. I know that this is the right path for me. We call this the sort of wise mind, and everybody has it when you kind of feel like, no, this is my decision. And that's really what we're trying to achieve. And so we want to be thinking about what are some of the thoughts and beliefs that you have, because those if we identify those and we share those, then we can take different perspectives. And that's where it's so important, because, you might look and say risk, oh, that's bad. But risk means opportunity. Opportunity, oh, that's good. So how do you go from risk to opportunity? And again, if you think about the relationship with health professionals, we can support people in terms of some of their attitudes, some of their beliefs. The emotions, we are emotional beings by definition. And so when you have emotional reactions, we shouldn't be suppressing them. We need to give them a voice, and the person needs to be comfortable finding someone to share. So with your feelings, you want to sort of reach out, have support, things like Diabetes Care Community. There's lots of great supports that are available for people living with diabetes. And this also then allows us to talk about our behavior. What do we do with regard to preparation, but also, what do we do with regard to management? Here's something that I've learned about about diabetes. The more work a person living with diabetes unwillingly does, the lower their quality of life. The more work a person living with diabetes willingly does, the higher their quality of life. So it turns out that the sort of the outcomes here, the quality of life, the emotional channel is more connected to making the right decision for you and then taking action on it. And this is where I think it can be really valuable rather than to think of, oh, what do I do to cope? Then we think, well, let me ask everybody who's listening to this, what do you do to cope? And then think about that. If those are your coping strategies, great. Now, do you have a plan B? Do you have a plan C? Do you have a plan D? If this doesn't work, what will you do? And there are so many different coping strategies. And in my experience, what happens with most people when they struggle is they actually have coping strategies, but they're not working, but they run out of strategies. And then that's when they get stuck. And so I think what we can look forward to here is really giving the essence of what would be very well researched psychological strategies like cognitive behavioral therapy, acceptance and commitment therapies that allow us to take advantage of strategies that address the cognitions, the thoughts, the beliefs, the emotions, and the behavior.
And, you know, Michael, we can certainly probably talk about this for hours, but when I think about sort of trying to put this into a little bit of a nugget at this moment in time, this is another area that we're going to continue to learn, right? Because we haven't had this in the public domain per se. And so, you know, when you talk about people are going to cope the way that they normally cope, they need to have information to make shared decisions, that they need to control their own pathway, that they need to break the news when it works for them. There's no right or wrong answer when it comes to all of those sorts of things, that they need to know where they can reach out for support, to be able to, you know, talk to other individuals going through this. Or maybe perhaps there might be a point in time where they're going to ask for a referral because they have a particularly difficult, let's not pick on teenagers, but let's pick on teenagers who are going through a rebellious stage and they're high risk and the parents are, you know, they don't know what to do, so that there will be no clear-cut pathway, but open lines of communication, shared decision-making. Those are the things that sort of resonate with me. Is there anything else that you can think of in terms of, you know, what about that poor child that is now feeling like over mothered or over protected or over monitored, and they just want to go play hockey or they just want to go play soccer?
Absolutely. Yeah, we call that miscarried helping, when you're trying to help and you're just over engaged, over involved. And so it can be very, very challenging in those situations. I think one of the things I would say, that I agree with everything that you've said. I think the one thing I would say is really that we need to give people time. I think I really feel like it's easy for us on the medical side to make decisions really quickly. But I would imagine that there will be, as any other behavior, early adopters. So there will be a certain group of people that are like, let me at this. I just really want this. Those are the active copers, but they don't make the entire population. And so I think we need to really learn from people. And that's what I'm really looking forward to at this point. So, you know, as a psychologist making these comments, please don't think, oh, I know exactly what I'm talking about. This is researched area. This is a new area. And we need to look at this area and learn from people going through it as well. So I think this is really the perfect environment that will allow us as professionals to really live the principle that diabetes is a self-managed disease, and our role is diabetes self-management support. And so in that way, I think we can really learn, especially if we give people the opportunity to not make a decision quickly, like to work through the process and to consider all of the various options. And I'm really looking forward to how not only can we benefit our clinical outcomes by the learnings that we have and we make, but I'm really looking forward to learning from the lived experience of people going through this so that we can begin to understand that. Like, for instance, I'd love to see what the diagnosis process is like when you have the preparation for it. So people with type 1 diabetes know their diversity. They know exactly what day it was that they were diagnosed. Most people with type 1 diabetes know exactly what hour it was. They can tell you, I was in this parking lot. I was told immediately go to the emergency room. That's a traumatic stress. That's a stress that is so impactful that it has like what's called a flashbulb memory, and you remember exact details. If I ask you, what did you have for dinner, on Monday, December 13th? There's no way you could remember that, but you can remember exactly where you were, what you were wearing when the diagnosis happened. And so I'm really looking forward to understanding what happens to the process of diabetes when you don't go through that, when it's not so traumatic. That will be very interesting to understand.
And I think the other thing to take away from all of this too, Michael, is you and I have been around for a long time. I think probably between the two of us, we have 80 years of experience in diabetes, And I wear that as a badge of honor that we've been around for so long because it shows commitment. But
I remember my first patient in 85.
Yeah. And I think that when we talk about this, the concept of, is it better to know or not know? Well, I think that that's really a personal choice. But now when you do know, there's a pathway, and there's a pathway of really amazing technology and knowledgeable people and monitoring. And this is a very small number of individuals in the population, a very important number of people in the population, but we have a strategy. We didn't have that a year ago, right? And then, when you think about, is it hard to overwhelm your child, or should you, shelter them? But, when you talk about the outcome of diabetic ketoacidosis, we can prevent those horrible outcomes. So, working through some of the psychological issues that go along with it could end up having a physiological benefit as well. And I think that, I'll leave the last couple words to you, Michael, but I just really think about, I mentioned earlier, diabetes is a family disease. And so, you have a reason that you're screening somebody. And now everybody in the family is impacted, both with knowledge and maybe concern. And so if you were to give us a few pearls to end up our session tonight, what would that look like in the family dynamics to you? That's a big question at the end.
Families are fascinating because you can always count on the fact that no one's in the same page. And, I work in the area of behavior change. And so I like to use the metaphor of a traffic light when it comes to how ready are people to make changes. And with families, the traffic light is a very useful metaphor because there's almost always somebody who's red light, stop, somebody who's green light, go, and someone who's yellow light, I'm not sure what to do. And so I think what's really important for us to reflect on is that, what do we know about people living with type 1 diabetes from childhood through adulthood? The vast majority of those people are super amazing people. They learn coping strategies and they develop a perspective on life that is different. They don't sweat the small stuff, so they're less neurotic than most people. They know that life is hard and that it can be tough sometimes just to get through a regular day. So they tend to have a little bit more empathy towards people. They're not quite fair weather friends as most of us tend to be. And so we see that there's so much that's when people are kind of put into a situation, they will manage it, right? This is one of the things that I think is pretty universal is watching people tap into their resiliency to cope. And what's nice about this concept of resiliency isn't to think, how do I get it? But to recognize, no, you have it. The only people who wouldn't have resiliency are people who would disagree with the following statement. And that statement is, life is hard. And if you disagree with that statement, then you've probably never been tested. But I have never met anybody who disagrees with that statement. And so when you think about that, what that means is that we've all had to struggle and we've all learned how to function. And that learning how to function is where our resiliency is. So I'm really optimistic, as you've been describing, about this shifting the perspective so that type 1 diabetes is taking on a new lens. And I don't know what the screening is going to offer, but I think it has such a potential to really combine the medical and the psychological, the the logic, the emotion, the knowledge, the education, but also the way of supporting people in moving forward. And as you know as well as I do, just how important the supportive relationship between a provider and a person living with diabetes can be. So I'm super optimistic about this, and I'm really looking forward personally to learning more about how some of what I've talked about tonight, how does it actually show up, and what can we learn about the journey that these individuals will be on.
Exactly. So, Michael, there's just one comment and this is not quite on topic, but I think it is a good one to answer perhaps in terms of, we talk about, so this is a group of people we're talking about who are going to go through the emotions of perhaps screening and then living with a positive result and wondering, but then, and likely this scenario is going to be well supported because it's new and people are going to be very conscious of this. But the question that came up in the chat is, I've been diagnosed with diabetes and I struggle. And, most of us as healthcare professionals, nurses, dietitians, endocrinologists, primary care providers, we're not all that comfortable. So when someone's struggling within a community, where would you recommend that they perhaps look to find some support? I know not everybody can see you, Michael. I wish they could. I wish we could have a 1-800 call Michael, but we don't. So what would your sort of guiding principle be to individuals who are struggling, newly diagnosed or even longstanding? Where could they find some resources?
Thank you. That's super, super useful as a question. I really appreciate that. Because, when I listen to that question, my first response is to think, oh no, please don't think that the diabetes community is insensitive to the psychological issues. But the question is really pointed. It's a great question, and it's really where we need to go next. So what I'll say in response to you is that the community in diabetes recognizes the lack of psychological resources. I've published work on this in Canada, where we see that diabetes providers say these are super important issues, but we don't really know what to do about them. And there are a number of clinics where the psychologists are connected. This is growing. I would reach out to, a Breakthrough T1D, Diabetes Canada, Diabetes Care Community. There's lots of good resources here. Please reach out to your healthcare provider. And what I'd like to recommend you do is talk about diabetes burnout and talk about diabetes distress. And those are two terms that are widely recognized by diabetes professionals, regardless of whether they're physicians, nurses, dietitians, pharmacists, what have you. We all recognize that. And so diabetes distress is becoming a really important concept. And then that has the management piece. I will also make the comment, I'm co-chairing a committee where we've worked with Breakthrough T1D and Diabetes Canada, and we now have a diabetes and mental health training program. So in recognition of this comment, we're actually we've got about 400 people in Canada who've been trained. So basically what this is, are mental health providers, so psychologists, psychiatrists, social workers, mental health psychotherapists in the country who take this program that educates them about diabetes. So basically, we would take the skill of a mental health provider and add on to that for the person, the diabetes. And then we're creating a directory. And so this directory will be available then. And what we are hoping to do, and the plan is to train about 1,000 providers in a 5-year period, and we're 3 years in. We're kind of on target to doing this. And then we hope that what this will allow people to do is at the diabetes centers, because right now what will happen is kind of what Lori just said. They'll kind of say, well, it's too bad we don't have somebody like you because we don't have these resources here. And we're trying to create this directory where we can move forward. However, even though there isn't that yet, it's in development, most healthcare professionals, and you can speak a lot about this in your own experience with diabetes in Canada, you kind of figure out who some of the go-to people are. So they're not obviously sitting there that you can access, but we can find those people. And I think to anyone who's interested in that, don't suffer in silence, please.
And I like the comment too, Michael, about Breakthrough Type 1 and Diabetes Canada and diabetes care community, because I also think that there are moderated support groups online that these people are aware of as well. So there is some support out there. I've just got a little pop-up to remind us that there's a section on the diabetes care community, healthy living and landing emotional well-being is there as well on diabetes care community. So with that, Michael, we're at our time. If I could get the next slide, I just want to thank you. I always learn like 7,000 things, but I take away one when I listen to you. And it's always a pleasure to listen to you talk and help us understand about some of the emotions that are related. To those of you that have joined us tonight, again, thank you. You will get an evaluation. A reminder as well that there is this webinar and the previous two and written communication around this topic are available on Diabetes Care Community. And also that what I'd like to point out to you is that we are only here tonight with support from Diabetes Care Community and the support from Sanofi Canada. So thank you again to those people. And Michael, it's always a pleasure. I look forward to seeing you again soon, and I'm sure we'll hear more from you as this area starts to develop. Thanks, everyone. Good night.
Thank you very much. Good night.